We'll be family. Just wait and see. Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see. Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see. Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you.
Hi everyone, and welcome to our Lung Cancer Living Room live from Atlanta. I am super excited to have everybody here. For those who don't know me, I'm Jennifer King. I'm the Senior Director of Science and Research for GO2 Foundation for Lung Cancer. And what we're going to do right now is go around and introduce everyone in the room. We're going to come back to our fantastic multidisciplinary panel in a few minutes, but we want to start with introductions of everyone in the room. And in particular, for the patients that are in the room, we'd like to hear not only your name, but when you were diagnosed, what type of lung cancer and stage of lung cancer you have, and if you have any specific questions that you'd like our panel to address tonight, knowing that we're going with the theme of biomarker testing. So we're going to start over here on our right. We have some microphones, which I will hand out over here, and we will go around and hear from everybody and hear all of your stories.
I have no story. Hi, I'm Kelly Byrne, and I'm with the National Lung Cancer Roundtable.
Hi, my name is Allie Burns. I'm with lung screening programs of the Department of Veterans Affairs.
Hi, I'm Sandy Spears. I'm stage 4 non-small cell adenocarcinoma. I was diagnosed in November 2015. I went through different surgeries, immunotherapies, clinical trials. I am currently in ED and have been since November of 2018.
Yay.
My name is Amy Hollifield. I am stage 4 angiocarcinoma, EGFR. I was diagnosed in June of 2017, stage 3A, and they wouldn't give me a biomarker testing until I was stage 4, which my personal opinions, don't like that, to be nice about it. Right now, I had a new spot in July that they just radiated. I finished radiation in November, and I think I'm NED again.
Yay.
Hi, my name is Brandy Bryant. I was diagnosed 2 years ago this month, initially diagnosed at stage 3B. I underwent chemotherapy and radiation, and when I had issues with that, I progressed because of pericardial effusion and was bumped to stage 4, and I began alectinib in May of 2018. Oh, I'm sorry. Stage 4 non-small cell adenocarcinoma, ALK positive. So I began alectinib in May 2018, and I've been in ED since June 2018.
Hi, I'm Terry Conneran, not local in Charlotte. I'm stage 3 non-small cell, diagnosed 3 years ago, actually I think it was yesterday. Went through 3 rounds of chemo and surgery, well, actually 4 rounds of chemo and surgery, was NAD for 2 years, and then had 2 recurrences last year, did an ablation and also did radiation, went in for a second opinion just in December, and was told after all that when I went in and was talking to the doctor, I was like, well, it's not like I have some sort of a biomarker or whatever. And she's like, well, yeah, actually, you're KRAS. I'm like, what? I'm sorry. Yeah. So 3 years into the journey, I did find out I was KRAS, it was G12D. And so according to that, even though we've been treating the PD-L1 and I've been NED, I was NED twice, right now I'm just treating this as chronic and waiting for next scans and such. And since the KRAS is considered such an undruggable biomarker, I'm starting this organization called KRAS Kickers to focus on that and bring more attention to it, similar to what they've done with ALK and EGFR and what have you. So happy to be here.
Hi, I'm Renee Westlake, and I belong to this guy, Bill. He's my husband. And we're both members of ALK Positive Outreach Management Group and are huge advocates for lung cancer and especially biomarker testing, for sure.
My name is Bill Westlake. I'm a local Atlanta native. I was diagnosed stage 4 2.5 years ago, adenocarcinoma. I was offered, when I was diagnosed, I was offered chemo, and I decided to pass and get a second opinion at MD Anderson. They did a liquid biopsy, and I said, what's that? Results came back 7 days later. They said, you are ALK positive, and I took really alectinib. It was just FDA approved for first-line TKI a week prior, or 2 weeks prior. Started it, and I haven't looked back. So feeling really good, stable as of last week. I'm blessed. Thank you.
Hi, I'm
I'm Angie Patterson. I'm with the Georgia Center for Oncology Research and Education, a nonprofit organization in the state of Georgia.
My name is Connor Phillip. I'm actually a medical science liaison with AstraZeneca, and I work on lung cancer.
Hi, I'm Jeff Gross. I was diagnosed in May of 2018, stage 4 EGFR, exon 19 adenocarcinoma. I was very fortunate because just a month prior, Tagrisso had been FDA approved, and because of biomarker testing, I was able to qualify. And I'm very thankful that I ended up with the right doctor that took that path. And so it's great to see everybody here, and thank you to Go-To Foundation for actually having this in Atlanta. And I'd like to introduce you to Laurel, my wife, and she's my rock.
Well, how do I follow that? So I'm Laurel. I'm the cheerleader, caregiver, and fan of Jeff Gross and everybody in here. We've been following the living room from our living room, and we used to live in San Carlos, so it's especially poignant for us to be able to come back to a place that was so dear to us, to people who are providing so much support. So thank you for what you do.
Good evening. My name is Lauren Rosenthal. I'm the director of the National Lung Cancer Roundtable.
Hi, my name is Stacy Chick. I'm with a company called Innovata. We are a provider of liquid biopsies specifically designed for patients with advanced non-small cell lung cancer.
Good evening. My name is Sanjay Jain. I'm a medical oncologist with Memorial School of Medicine.
I'm Karen Beard. I'm director for the Georgia Society of Clinical Oncology and member of the Georgia Lung Cancer Roundtable.
My name is Michelle. I'm a nurse navigator with lung screening at Northside Hospital.
Good evening, my name is Bruce Yeager. I'm also with Innovata.
My name is Steve Ingram. I'm with AstraZeneca.
Greetings. Hi, my name is Stacey Douglas. I'm a medical science liaison with Genentech. I work closely with clinical trials for lung cancer.
Hi, my name is Jason Long. I help maintain, there's a cancer cluster in South Atlanta. I maintain the clinical and demographic data for that group, and I'm looking for help for after the group, so I'd love to talk to somebody about that. I've been doing that for a long time now. And really, Samantha is one who has done it for a long, long time.
Hi, I'm Samantha Nixon. I was diagnosed November 2012, stage 4 EGFR mutation, non-small cell lung cancer, and had radiation, all that other stuff. And I'm here, so thanks.
And I'm Samantha's mother, so I'm here to support her.
My name is Kelly Peace. I work for Genentech. My title is Biomarker Testing Specialist, so I'm delighted that you all are here, and we are huge supporters of the Go-To Lung Foundation.
Good evening. My name is Tracy Mason. I'm with AstraZeneca, and I've been in the lung franchise for the last 5 years. Passionate about screening and biomarker testing.
I'm Lisa Moran. I'm from Colorado Springs, Colorado. I am here with Team Draft on the way to the Pro Bowl for the Lung Cancer Survivor Super Bowl Challenge. And I was diagnosed with stage 4 non-small cell lung cancer, adenocarcinoma, EGFR mutation, exon 19 deletion. I've been on targeted therapy since September of 2015. I've had radiation to my primary tumor, a new tumor, and to my spine, and I'm currently on Tagrisso as second line of treatment.
Hello, my name is Travis Harper, and I'm with the Team Draft Foundation also, and I'm very honored to be able to follow Lisa for the next week at the Pro Bowl and just enjoy her experience. Thank you.
Hi, I'm Patty Kiesler, and I was diagnosed less than a year ago, February 2019, non-small cell adenocarcinoma, stage 4. I've had gamma knife radiation to the brain by a wonderful Emory radiation oncologist, Shannon Kahn. She's my Wonder Woman. She saved my brain. I've been through several rounds of chemo, just traditional carboplatin, because initially I did not qualify for any of the acronyms. But another wonderful Emory doctor, Stephen Zabo, insisted I have foundation 1 testing very early. They discovered a very rare gene mutation that I have. It's an EGFR exon 18 to 25. And when the chemo stopped working, we started me on Fatinib, and I've been doing that for about 6 months now, and it seems to be working. And I know it's only 1 or 2 patients in the country who have my gene mutation that have used the Fatinib successfully, but I'm hoping to be another example.
I'm Eric Anderson, was diagnosed, like Jeff and I guess Lisa, in April of this past year with non-small cell stage 4, had foundation testing, and it was EGFR exon 19 deletion, and I had started immediately on Tagrisso since May. It has been working, and everything is stable, and there was no new uptake the last screen, so that's good. I did have gamma knife radiation on a number of bone lesions on spine and elsewhere that was also amazing technology, and we're very grateful for that. So I feel pretty lucky at the moment, and hope this continues working for a long time.
I'm Ellen Anderson. I'm his rock, but he was my rock 20 years ago when I had acute lymphoblastic leukemia. And I didn't have a bone marrow match, but I did 2 years and 9 months of chemo, brain radiation, and I'm cured.
Good evening, I'm Margaret Trumoyer. I'm from Amgen, and I work in the research division there, and we are trying to discover new therapies for cancer.
Hi, my name is Cindy Sodarg. I live here in Georgia. I was diagnosed in September of 2018, stage 4, EGFR. I am taking Tagrisso. It's been 15 months. I had a little bit of progression to the brain recently, but we're going to take care of that with some radiation. I'm feeling great and hope to stay on Tagrisso for a long time.
I'm Tina Gaeta Pink, and I'm an advocate.
I'm Joe Gaeta. I'm Tina's brother. Our mother passed away from lung cancer about 12 years ago, and we go way back with the Adarios. In the previous decade, we raised a little bit of money and caused a little bit of noise, but it's been a while since we've been involved, and must say I know there's a hell of a lot of work that still needs to be done, but being away from it, coming back and seeing all these success stories and seeing how far everything's come, sometimes you should stop and pat yourself on the back, because it's absolutely amazing. I can only wish that my mom had been here now, what her life could have been like. So, congratulations.
I'm Paul Scheinberg. I'm a pulmonologist, now retired, but not ready to give up my passion with dealing with lung cancer. As a pulmonologist, my focus was on diagnosis and staging rather than therapeutics, other than some palliative interventions. But it's been my pleasure to lead my hospital's multidisciplinary program, and I noticed the panel is very thorough, but without a pulmonologist representing.
That's true.
Nevertheless, we think that we're the starting point. Anyway, it's a pleasure to be here. Oh, and I am a very good fan of Bonnie Adario, whom I met when we were involved with lung cancer screening. I'm a passionate advocate for early diagnosis and screening.
It's a pleasure to be here. My name is Paul Cifuentes. I do represent also Amgen from a global medical affairs perspective. Thank you for having us.
Good evening. My name is Sanket. I'm also with Amgen. And first of all, let me just say how floored we are with these stories of courage and perseverance. So thank you for sharing these. As Margaret said, we've been working in the field of lung cancer, trying to discover new therapies, including targeting KRAS. So thank you again for having us here, and to GoTo for putting this event.
Absolutely. Are there a few people we're walking in late? Are there a few we missed?
There's a fellow in the back standing up.
Mm-hmm. One here and then in the back.
I'm Chris Draft, former NFL linebacker and founder of the Chris Draft Family Foundation, and Team Draft, co-founder of Team Draft, that was founded with my wife Keisha on our wedding on November 27, 2011. And so from that time, we've been changing the face of lung cancer. And Lisa's down here, and also that Samantha is here. Both of them have been a part of our Super Bowl challenge. The other part is exciting to see all our Emory survivors that have been a part of the support group that Patty Watkins, who's not here, I know she maybe texted a number of you guys, but wanted to make sure to give her a shout out because of her efforts and a lot of other people. There's a support group that even after this living room is over, there will still be a place for people to go to. So, thanks.
I'm Iwana Bonta. I'm a medical oncologist at Northside Hospital, and I'm here with Tim Westlake tonight. I have to say it's very nice to finally put a face with a name. I've been on a phone call with you before, Chris, and I've been hearing a lot about the work you do in lung cancer, and thank you to all of you for being here tonight.
Great. Thank you, everyone. As always, we are humbled by all of your stories and so thrilled that so many patients and caregivers can join us in the room tonight. Now I want to move to introductions of our panel, but I also want to remind everybody that this is not just a conversation between us up here. We want all of you to ask questions and to be involved throughout the evening. There are multiple microphones throughout the room, so if you have a question about something that anyone is saying, feel free to request the mic and go ahead and ask away. So as pointed out, we have a very multidisciplinary group. I'm going to have them all introduce themselves, tell you what discipline they represent and what their title is. And then I'm also going to ask all of you to tell everyone how you got into lung cancer. Why are you a lung cancer doctor, where you sit in your area? So we will start with Dr. Ramalingam.
Good evening, everybody. It's truly a pleasure to be here and share our experiences about lung cancer tonight. My name is Suresh Ramalingam. I'm a medical oncologist. I am the Deputy Director of the Winship Cancer Institute, about less than a mile from here. I have been involved in lung cancer patient care and research for approximately 20 years now. If I can think of 2 or 3 episodes during my career that drove me into lung cancer, one episode I would say is when I took care as an intern in residency training a 43-year-old male with newly diagnosed lung cancer. This was 1993, and I didn't even know at the time, even though I was in residency, that you could get lung cancer at such a young age. And at that time, lung cancer was sort of a bad disease and had a lot of taboo. So just taking care of him and providing the initial diagnostic workup. I was not his oncologist, I was not even an oncologist. But that experience struck me a lot, and then I happened to walk into a researcher working on lung cancer who had just moved to my institution at that time. This was way back in Detroit at Wayne State University, and he was interested in small cell lung cancer, which was a very treatable form of lung cancer in the 90s, and not as much non-small cell then. And I worked with him closely for a few years, and that really deepened my commitment to working on lung cancer. And since then, I have not looked back. I have immensely benefited from my career as an oncologist. I've met some remarkable people along the way. And I've also taken pleasure in being able to bring some new therapies to our patients in the form of clinical trials. And I'm learning every day from every patient that I see.
That's great. That's always one of our goals, to learn from every patient.
Thank you.
And we have Dr. Moghanaki.
Hello, my name is Drew Moghanaki. I am a radiation oncologist at the Winship Cancer Institute of Emory University as well. I'm also the section chief of the Department of Radiation Oncology at the Veterans Affairs Medical Center here. I've been in the VA for almost a decade now, and I currently lead 2 national projects in the VA. One is the VA Partnership to Increase Access to Lung Screening, which is implementing screening at 10 VA medical centers. The other one is I'm the co-chair of a phase 3 randomized trial of stereotactic radiation compared to lobectomy for stage 1 lung cancer. I am incredibly inspired by survivors, and I want to thank GoTo and my former involvement with Lung Cancer Alliance to get to meet a lot of you, because it's changed the way that I teach our residents. And just this morning, I was sharing a story of survivorship to our trainees who, if you think about it, from there, if you were to be in their seat, they may see you once every 3 months or once every 6 months, and may never know your journey, what it's like to be at home, talking with people about your journey. I've recently, for example, changed the way that I talk to my patients. I ask them, do you talk to anybody else with lung cancer? And every now and then I meet someone who says, nope, just you, once every 3 months. And I'm thinking, wow, what a lonely place to be. And I'm so glad that organizations like this exist where they can connect, especially through social media. How I got into lung cancer was I was in my first year of medical school, and my favorite uncle was diagnosed with metastatic small cell. I quickly left school, flew to California to be with him, and shared some very precious time with him about what life is all about. And the whole time I couldn't believe that this disease was stealing him from us. And so when I went back to medical school several years later, I was very fortunate to meet an outstanding medical oncologist with a very robust translational laboratory at Vanderbilt University. His name is David Carbone. And he taught me that anything is possible for a disease at a time where, if you went to national meetings, the room that was discussing novel breakthroughs in lung cancer was largely empty. There was very little hope for this disease, but ever since I was a child, I was raised to tackle the toughest problems you can find and make a difference in your lifetime. And so I jumped on board with lung cancer and was just remain delusionally optimistic that someday breakthroughs would come. And I was just thinking of, that arcade machine where you keep putting the quarters in and it keeps sweeping them forward and sweeping them forward. Well, if you keep pouring billions of dollars into a problem, eventually the quarters will start falling. And lo and behold, in the last 5 years, we've got all these FDA approvals that are actually finally coming to light. And I'm so glad I made this, this investment of time since I was in medical school several decades ago.
That's great, and I think we have some evidence in the room of those fantastic advancements
Exactly.
and the FDA approvals as we look around tonight, which is great. We should also mention that Dr. Moghanaki is a member of our scientific leadership board for GoTo, and Dr. Carbone is the chair of the scientific leadership board for our sister organization, Alchemy, so lots of connections in here. And then we'll move to Dr. Khullar.
Yeah, my name is Onkar Khullar. I am a thoracic surgeon. I work at Emory, and I am the thoracic surgeon at Grady Hospital as well. Was previously at the VA hospital for a long time, and then recently in the last year moved to Grady to start a minimally invasive thoracic surgical program there, so that some of our less fortunate community members had the same opportunities. My lung cancer journey probably started when I was in medical school, when I was doing my first surgical rotations, and I had the opportunity to observe some lung cancer operations, a lobectomy, and even then see how, for some of these earlier stage lung cancer patients at that time, how a lobectomy could really provide significant benefit and potentially cure these patients. And then as I started my surgical training, early on my surgical training was the advent of the minimally invasive era in thoracic surgery, and so I got to see how you could tie in these cutting edge surgical technologies with potentially curative operations. That has only sort of over time in the last 10 years kind of exploded with more advanced minimally invasive techniques, robotics, more endoscopic techniques. And so very early on in my surgical training, I decided that lung cancer was going to be what interested me the most. And then as that continued to develop, I got more interested in clinical trials and the research side of it. And then so I decided to marry the two of those. And so that has been the focus of my career ever since.
Fantastic. And Dr. Hill.
So my name is Charlie Hill. I am a pathologist. Specifically, I am a molecular pathologist. I direct the molecular diagnostics laboratory for Emory Healthcare. So we do some of the molecular genetic testing to establish the various mutations for the lung cancer specimens. My interest in lung cancer probably started in graduate school. I did a a lot of work in graduate school on the mechanisms of a variety of chemotherapeutic agents, particularly the cytotoxic variety, so the older style of chemotherapeutic agents. But at that point, it was all in childhood ALL. And over time, much the same way as some of my colleagues up here, it became very apparent that lung cancer didn't have some of the chemotherapeutic responses that other types of tumors did. And so really wanted to get involved with that. And then came to Emory for residency and fellowship, and as a result of that, with growth of biomarkers coming into the clinical arena, actually my first mandate as a junior faculty member was to bring in sequencing for a variety of tumors, and lung cancer was one of those.
Fantastic. So I'm going to start with what seems like a simple question, but can be fairly difficult as you dive in. And I'll start with Dr. Ramalingam, but I'd like all of you to weigh in, which is, what is a biomarker? What is biomarker testing? And how do you describe it to the patients who come in?
Sure. So biomarker is some biological information from an individual that predicts something else about how that individual's course is going to be. It could be that if you have the mutation, you're going to respond to this therapy. So the mutation there is a biomarker. There are markers that tell you if you have this marker, you're probably going to live longer. That's also a biomarker. And then there are markers that are used in certain instances to say whether a particular treatment will be tolerable or will be more toxic to that particular individual. So we can use this information for a number of things. In the sense we're talking here in lung cancer, we refer to biomarkers primarily to help us understand what therapies are going to work for the given patient sitting in front of us. About 15 years ago, when we took care of lung cancer patients, every patient got the same treatment. If they had stage 4, everybody got the same platinum-based chemotherapy. When that stopped working, they went on to get another chemotherapy. We didn't know why some patients, even with chemotherapy, did really well, and some did not do very well. Now we have the sophisticated information to take a given patient's tumor or their blood, conduct tests, and understand what specific treatments are the most likely to work for them. Not only that, after we have a patient on treatment, at some point, if resistance develops to therapies, we can go back to the biomarker testing and understand why the tumor developed resistance and think about what might overcome that resistance so the patients can go on into the next inning of their lung cancer fight. So a biomarker can be used in many terms to define something, but what we're talking about here is to take some biological information from a given patient to help us decide what treatments work best for them.
And that's not a single test, right? In a lot of cases, and would you like to speak to, or maybe Dr. Hill to start, what different types of tests go into what we talk about as just biomarker testing?
And that's a great point, because from the pathology side, we would like to think, and I would argue that we have been doing biomarker testing for decades, for almost 100 years, because we've used antibodies, immunohistochemistry, where we take a monoclonal antibody to a specific protein, and we can detect protein, we can quantify it in a specific tumor cell, and we do that on glass slides. But that's protein testing, and that is a variety of biomarker. We also do molecular genetic testing, and so the genetic profiling of the tumor, there are a variety of mechanisms, tests that we can do for that, whether it's very, very specific. I heard KRAS G12D. We have tests that test is specifically for that. Is there a mutation of the codon G12 of KRAS? So single gene, single marker testing. But then we now have expanded out to multi-gene, multi-marker testing, and that now has provided very large amounts of information, and it can be very clinically helpful, but at the same time, managing all of that information, how do we go back and reanalyze that data as new drugs come out, is something that's an interesting question that we all struggle with today. But we've got some of that biomarker information. We just like to be able to remine that data periodically.
So an example of the protein-based testing you talked about would be PD-L1, which we heard
Absolutely.
someone talk about today. Right now there's a lot of questions, I think. What are the current guidelines on who should be tested and for what? If you're a patient with, let's start with stage 4. Stage 4 lung cancer, possibly non-small cell, but you can all comment on that. What should you be asking for if you come in and you want to have biomarker testing? Open to anyone on the panel.
Yeah, I would say that for anyone diagnosed with stage 4 lung cancer now, biomarker testing is a must before you start somebody's treatment journey. Now we look at lung cancer broadly, as you're already aware of, squamous cell, adenocarcinoma, and small cell. In small cell lung cancer, we're still trying to figure out what biomarkers are helpful in predicting. So I would leave that for now and talk more about adenocarcinoma and squamous. In adenocarcinoma, the biomarker testing should include looking for the various genes, mutations, fusions. ALK is a fusion, EGFR is a mutation. Those are just different ways by which the changes in the DNA sequence affect the biology of the tumor. So we have about 5 targets in lung non-squamous tumors that have FDA-approved therapies. EGFR is one, ALK is another, ROS1 is another target, BRAF mutations, and finally NTRK mutations. Now there are a few other targets for which there are some very promising treatments that are not too far from being FDA approved. Examples would be RET mutation fusions and MET fusions. And then there's another other promising therapies. KRAS G12C is one where we have some exciting developments in the clinic. So as you start adding up the number of markers that you need before you will have good information on what treatment is going to work for the individual, it's just an expanding list. So the next generation sequencing approaches are now the most commonly used in the clinic. What that means is you're looking for all of these markers at the same time with one test, as opposed to looking for, okay, I'm going to look for EGFR. Well, there's no EGFR. Okay, let me look for ALK. There's no ALK. Now let me look for KRAS. So that was a sequential testing approach that was initially used. Now the wider platform, do one test, you have limited amount of tissue. Often you don't have a lot of tissue to do one test, go to B, to C, to D. So you do one test and you get all the information. The other key piece of information is the PD-L1 expression now that we are using to decide if immunotherapy would work for a patient. For squamous cell lung cancer, we would want the PD-L1 testing before we make treatment decisions. For patients who don't have the mutations with adenocarcinoma that we can target, we would want their PD-L1 expression level as well to guide immunotherapy treatment approaches. So these are the markers we use in clinic. This is obviously a list that's expanding as we speak from month to month, if not year to year. And this is helping us personalize therapy for our patients. Now, there are rare instances where a patient's condition, unfortunately, is declining so rapidly that you don't have the time to wait for the test results to come back, and you have to make a treatment decision that day. So in those instances, we would start patients on chemotherapy with the hope that within 2-3 weeks we will have the molecular data available, and then we can make appropriate adjustments to treatment based on that. So the chemotherapy in this instance helps keep the patient stable, help them feel a little better while we have the definitive information available. So that's what we do in our practice. Biopsies based on liquid specimens, the peripheral blood, is becoming more widely adopted in clinic. So these days it's possible to, if there's not sufficient tumor tissue, to test the blood and have that information available in a week or 10 days to make treatment decisions. All of these tests have some caveats. For example, the liquid test may not detect the mutation in 100% of the patients. There's a 20-30% patients where it'll miss it. So we need to be aware of the limitations, but certainly these have greatly enhanced our ability to personalize treatment for patients.
I think it's a great question and something that we struggle with every day. For instance, we've started sequencing at Emory in about February of 2014, and initially we started with a relatively small panel of genes. Now, back to high school biology, everybody in the room probably learned that there are about 30 to 35,000 genes. That actually is no longer correct. There really probably are only between 15 and 17,000 genes that are relevant. A lot of DNA just kind of holds the rest of the DNA together, although there's argument that it may be regulatory and there are other things that could be going on. The reason I bring this up is deciding how big of a cancer panel to do is a real challenge. We don't need all 15,000 genes because a lot of those genes have nothing to do with cancer. And therefore, we have to carve out subsets that we think are relevant. But it's a moving target, and more information is usually better, and therefore we like to do as many as we can when it comes to the sequencing data. Inevitably, we run across things that we don't know what mean. It may be the right gene, for instance, EGFR. We may find an EGFR mutation, but it may be what we would call a private mutation, that hasn't been described in cancer patients on a regular basis. And these variants of uncertain significance are things that we have to run across and have conversations about what we think this might be doing. And with more research and with more analysis, I think we're going to get to the bottom of that. But it's a very different world today than it was just since 2014, because the panel we were doing then, which was relatively small, is not adequate today. And it also now, with some of the newest drugs, and particularly when we talk about immunotherapy, I think what you're going to see is some of these DNA-based panels get even larger because of a concept called tumor mutational burden, where the immunotherapy, we believe, is going to work better when you accumulate these mutations in your genes, and your proteins then produce novel markers that your immune system can actually attack. And so tumor mutational burden requires then to accurately measure, we have to get a certain number of millions of bases of DNA sequenced to really get an accurate number. So as a result of that, you're seeing gene panels from Foundation 1 that's in excess of 300 genes. Caris and others are in the 300 to 500 gene range. I have a colleague at the University of Chicago who has a 1,200 gene panel. And so we don't know the right number today, but we know it's bigger than what most of us do on a regular basis.
That's great. And just a note for everyone watching, you know, the terminology can be really difficult around all of this. We tend to use the phrase biomarker testing or sometimes molecular testing because it encompasses multiple different tests. Biomarker testing is broad enough that it counts both those larger next generation sequencing panels, which also can be called comprehensive genomic profiling panels. There's a lot of different words here. And the immunohistochemistry panels, the protein-based panels that look at things like PD-L1. So that's why the go-to materials will advocate biomarker testing, because we want it to be broad enough that you're getting all of the different tests that you would potentially need. But there are conversations to be had here about what's appropriate for each individual patient. But we want everybody to be getting enough and broad enough biomarker testing in general. With that, I want to go back. We've been talking a lot about stage 4 and recommendations there, where there's a lot of tests out there. But as we said, we have a multidisciplinary team. I want to hear from our other panel members. We'll start with surgery, and then we'll move to radiation. But when you're thinking about biomarker testing in a patient who's going to undergo surgery, which in some cases could be looking to be curative, what do you recommend? Do you recommend biomarker testing? Do you use their surgical sample? Do you test ahead of time? What does the recommendations look like for the different surgical cases?
Yes, it's an interesting question. So, right now we don't tailor the way we do an operation based off of a biomarker, because the biomarker is looking at more at how someone's going to respond to a drug, not necessarily a surgery at this time. There are studies that are looking at whether giving some of these drugs before surgery for these patients who we right now think are curative is going to be beneficial. And I put the word curative in quotes because, yes, we do a great job with surgery for patients with stage 1 and stage 2 lung cancer, and we can potentially cure them. But what we do know is that a very high percentage of people after surgery will recur. It's higher in lung cancer than it is in most other cancers at early stages. And so there are ongoing studies looking at whether these drugs can help someone before surgery to reduce the tumor burden so that we can go in surgically and then remove what's left and reduce their recurrence rates. Those studies are ongoing. And so at the moment, there is not much of a role for biomarkers before surgery. That being said, after surgery is where the biomarkers become very, very important. So it's very useful to, after we've removed the surgical specimen, to do these biomarker testing because we can profile a patient's tumor, and whether or not they need the therapies, it can still provide beneficial information, because if that patient then a year or two down the road, their cancer comes back, we have now we have these profiling biomarkers done beforehand. And so if it comes back in some place where it's difficult to get adequate amounts of tissue to do all this testing, there's plenty of tissue available for surgery. So, we routinely send all of our surgical specimens for biomarker testing, whether or not someone is going to need biomarkers afterwards, because you never know what's going to happen 2-3 years down the road.
Great, thanks. And what about radiation oncology? How are you incorporating any thoughts of biomarkers into that area?
Yeah, well, one thing I would say is a lot of times we do rely on surgery to get sufficient tissue. A lot of times when we're treating with radiation, we might not be able to get the right amount of tissue. With that said, radiation is typically used for all stages of lung cancer, and often we are kind of the most important part of stage 3 lung cancer, which is still in this quote curable category. Right now, the 5-year survival, most recent studies show about 30% are still alive at 5 years. This is before conventional targeted therapy, so maybe it's even higher now. So how do I use it? Well, if that information is available to me, it gives me a really nice roadmap. I'm very excited about biomarkers because when I look at just adenocarcinoma or squamous, you put 10 patients in front of you, you give them all the same treatment, they're not all going to have the same outcomes. So you're really blindly guessing. And I worry that sometimes physicians, if they're cognitively depleted at the end of the day, they may not want to go the extra mile for a patient because they lump everyone into the average. And we know that no one's the average, especially today with biomarker testing. So now if I have a patient who's an EGFR positive patient, I'm very careful with what we're doing. I'm looking long term at this person. And unfortunately, if I have a patient who just has no mutations at all, we may adapt how aggressive we might be, kind of prioritize quality of life over, aggressiveness of treatment. But with that said, it's really when it comes to tailoring radiation therapy, so many decisions go on. How are you going to design the treatments? Whether you're going to add aggressive chemotherapy at the same time, how much dose you want to give. And we have lots of factors to try to predict how a patient may tolerate that treatment or how long they may live, but today at least we have a much better projection of knowing what their long-term survival might be. And also, as radiation oncologists, we can buy liaisons to get the patient back to their medical oncologist as quickly as possible for additional therapies because they're really in the trenches with us for a very long time. We talk to them every single week while they're undergoing the radiation. That provides us with the time for counseling and education so that they're prepared for that, again, that next journey in their trajectory.
And one other thing that I'll add is that there, regardless of the local therapy, whether it be surgery or radiation, there are, even for stage 1, stage 2 cancers where there's not a lot of evidence for, we don't know whether these targeted therapies will help after surgery. There are several ongoing clinical trials looking at people who have had a local therapy and they have their tumors are positive for a biomarker, and giving them targeted therapies after their local therapy, and then kind of seeing if there's going to be a benefit from this. And these studies are ongoing. Some of them have actually completed enrollment, and we should have results soon. But I think in 5 years we may find that if you have an EGFR mutation and you have stage 1 lung cancer and you have an EGFR mutation and you have surgery, there may be benefit to taking these therapies afterwards, when before we found giving patients such as that chemotherapy really was not very beneficial. But so I think it's important that whatever local therapy you have, that you be tested for biomarkers.
For the patients that aren't self-advocates and self-educated, you started the conversation of what should the patient ask the doctor about biomarker testing. How far are we from that being standard line of practice across the board, and the doctors are telling the patients about it and not the patients asking the doctors?
Yeah, that's a great question. I think we have made good progress, but we're not at 100% yet. We see a lot of barriers to biomarker testing. The United States is doing better than some of the other countries, but we see when we look at reports from patient chart review kind of projects, that maybe 20-25% of the patients are not getting biomarker testing, or they're not getting all the biomarkers that you want them to be tested for. For example, EGFR testing is far more widely adopted compared to some of the less known markers like BRAF mutation. So biomarker testing being studied in routine practice is still a work in progress. There is an educational need. We need to educate our colleagues to make sure that they are incorporating biomarker testing in their practice, and periodically making sure, as Charlie said, is the panel they're using capturing all the genes that we want them to test for, and are they upgrading their practices accordingly. I think for a patient diagnosed with lung cancer, it's a very reasonable thing to ask the physician, am I a candidate for biomarker testing? Have I been tested for all the markers for which there are FDA-approved therapies? And to make sure that you're at a facility where you have the multidisciplinary team to care for you. Now, Onkar and Drew talked about biomarker testing for stage 1, 2, and 3 patients. I include them in the care of stage 4 patients day in and day out, because we have patients with EGFR or ALK who are on a therapy, and at some point you find one spot growing while everything else is under control, and that's when we bring them in and say, hey, is this something we would go in and operate? Even though this is a stage 4 patient, we wouldn't operate, or we wouldn't do radiation for a single spot. Now they are more and more involved in the management of stage 4 patients along the journey, either with surgery or with stereotactic radiation. And we bring in Charlie into conversations. Hey, this patient is already on therapy. We found a resistance mutation. What does this mean? Some of these mutations sometimes we've not heard of, and we need their help to help us understand. So this particular team taking care of you, I think, is the most important thing for a patient with lung cancer. Be at a place where there is a team of multidisciplinary experts who have experience taking care of you, so you have the best chance of making it. And I would also say, make sure that this place where you're at has access to clinical trials, because you may have a rare gene for which there is no proven therapy, but there may be promising clinical trials that you want to be educated on. It's finally your decision whether you want to participate in the trial or not, but you want to have that information as part of the decision-making process.
So I just wanted to add on to Lisa's question, the idea that that someone that's just diagnosed would have any clue about biomarker testing to know to ask that. Is that a strategy that we really want? And then the other question is, if we know that it's 25% that potentially aren't doing that, are we saying 25% based on approved drugs, right? Are we saying that there's 25% that aren't doing about, do we know who they are? So that we can make sure that we hold them accountable. So that there's not 25%.
Right.
So this is a topic Chris and I talk a lot about, and what he's talking about is diffusion of knowledge, awareness amongst the medical community. And and Chris has recently been asking about accountability, and it's a tough topic. Not everyone graduated in the last 5 years. I would assume that those physicians are all routinely ordering biomarker testing. But if you're a medical oncologist who took to a clinic in rural America, may not be reading, not talking to your colleagues, not logged into this Facebook live stream, may not be just not aware. And it's important for, I think, everyone to know that the knowledge gap has reasons. And those include, even 5-10 years ago, we only order genetic testing for these people. So if someone learned that, and that's what they know, now where's the information going to come for them to unlearn that and learn the new? And I just had a wonderful medical student at Morehouse at the VA yesterday talking with me about what he wanted to do for a career. And he thought he wanted to go into radiation oncology. And I was saying there was a time where there wasn't a lot of progress in medical oncology, and radiation oncology was probably the most rapidly evolving field. But right now, I mean, medical oncology is it's a fast-moving field. There's a lot of new information coming all the time. So I think that programs like this to diffuse that knowledge out there is needed. Chris, I think if there was a simple solution, if there was a lever, we'd pull on it. I don't think there is one lever to fix this problem.
Well, and I know it's not a simple solution as much as the acknowledgement that if the people on top are learning at a quick pace and the other people aren't there, then we need to share that information. And so we have to have a sense of urgency in sharing, along with putting in practice the idea of recognizing in this room, it's basically someone that's had a mutation. That's why they look so good, right? So we know that we've had tremendous advancement in that. So to miss anyone, and I'm essentially saying that by the idea that in breast cancer, would it be okay to miss anyone that is HER2 positive? Would that be okay? In lung cancer, is it okay for us to miss somebody that's ALK positive? Is it okay to miss somebody that's EGFR positive? Because if there's 25% that aren't doing it, then that's essentially what we're saying. It is okay to miss those people.
I don't think most of us think that it's okay. I mean, I think that's the reason for forums like this.
If we're not
that's
holding
the forum.
accountable, then it's okay.
Well, no, I mean, that's what I was going to say. GoTo has a Community Hospital Centers of Excellence program where we are trying to increase testing rates, hold people accountable to different quality programs. I think there are a lot of people working on it. I think we still have a ways to go. To your point, we are not there yet, and it's not acceptable. But as a community, I do think we are at least going in the right direction. And hopefully,
knowledge is expanding.
It's personal to me, just in the fact that my wife passed after 1 year. So I know if we don't get it, that there's a drastic difference between the outcomes. So it's not just, hey, we missed it, but that could mean a completely difference in terms of.
I mean, knowledge is expanding at an exponential pace. And if you just look at a calendar year, FDA approves 30 to 50 drugs for cancer. And if you're a community or if you're a general oncologist who takes care of all kinds of cancer, it's just simply not possible to know everything that happens on a day-to-day basis. There is a gap, and all of us have a role here in educating our colleagues. If you ask me about what's the latest drug approved in leukemia, I probably couldn't give you the answer to that because all we do is specialize in lung cancer. And I think even in the practice settings, people are beginning to get into this specialization mode so they can be on top of their game for a certain disease, acknowledging that it's not possible to be a jack of all trades when it comes to cancer care.
But with that said, Chris, we're not going to stop trying to advocate until we get 100% of all oncologists in this country and around the world fully aware that you must order biomarker testing for all stage 4 patients.
So just on that point related, I wonder if you could speak a little bit about NCCN guidelines for molecular profiling for advanced non-small cell lung cancer patients. There's been extraordinary progress made by the National Council, and I just wonder if you could speak to that as to how that's the leading edge of getting all physicians, all thoracic oncologists in particular, focused on how to profile and help treat patients much more quickly.
Right. Charlie, do you want to take that? Or I can say that there are many guidelines out there that are very helpful in helping us navigate patient decision making, particularly when it comes to biomarker testing. Charlie is part of the AMP, American College of Molecular Pathologists group, which has also put out very authoritative guidelines on this topic, which has been adopted by IASLC and other groups. NCCN guidelines are very helpful for biomarker testing, for treatment. I think the most important piece of information we can give our colleagues is that it's important to have biomarker testing for our patients and make sure that your panel meets all the major guidelines.
I agree with that, and I think this is sort of a two-edged sword. Because the most recent update to the ISSC CAPAMP guidelines, sorry, that's just 3 different organizations. They came out in 2018. A lot of progress has been made in the year and a half since that came out. Traditionally, and I would say this of any medical guideline, they're evidence-based. They're, for lack of a better word of describing it, conservative. They want strong evidence or consensus expert opinion. And I think we all do need to remember that at the end of the day, they're still just guidelines, because every patient is different. And the patients don't read the textbooks. You know, we always talk about things like mutual exclusion of KRAS and EGFR, but there are rare patients who have both. And so inevitably, the guidelines are absolutely critical, and I think any practicing physician in whatever field they're in should be keeping up. And to be fair to the medical community, and I will throw my own specialty under the bus on this one, all medical specialties, according to the American Board of Medical Specialties, are now required to have continuous or maintenance of certification. You have to keep up. And pathology was the last to do it, so that you know. And therefore, I think part of that continuing education and continuous certification of physicians really has to be focused on keeping up with what the current guidelines in our fields are. Having said that, it's probably going to be another year before another revision of the CAPAMP ISLC guidelines revise again. But it's coming, because we already know that there's information, clinical trial data that probably needs to be incorporated.
Kind of going along with what everyone else here was asking, I know that pilots and everyone else have to do these continuing education classes. How often do you all have to do them, and how often are they published?
So there is some slight variation from organization to another, but for medical oncology, for instance, now there is a requirement that you take an exam. You can take an exam every 10 years and still take a minimum number of credit hours by attending some of these educational events every year to show that you are updated. Now they are introducing exams every 2 years that you can take a lower intensity exam. So there are different ways, but the consistent theme across is everyone recognizes the need that we need to constantly update ourselves. And in Georgia, we have a number of programs across by various stakeholders to educate the cancer care community. Karen Beard is there from GASCO, and at GASCO we conduct 2 or 3 meetings a year to educate our oncologists across the state. At Winship, we have a number of educational events throughout the year for various cancers, which are multidisciplinary continuing medical education conferences. So there are a number of these initiatives that are ongoing. There's online resources. A lot of times it comes down to how much time you have as a busy physician and provider. If you're being in clinic since morning to evening and you come back, you have to complete your charting. So there are barriers to people getting what they need to do in a 24-hour period. However, there are enough mechanisms in place for people to get updated.
Yeah, I was just wondering because, I mean, you were saying sometimes it could be 10 years, sometimes 2.5 years. Like who holds everyone accountable for all of this?
Each specialty has a board.
Uh-huh.
So ours used to be once every 10 years, so you could be 9 years out of date
Yeah.
and then crash studying a lot. But now they change it. I think we're getting questions every few weeks to every month, yeah.
Okay, and even in the rural areas, there's somebody to hold some kind of accountability over the hospitals in rural areas, or are people supposed to know that they need to go to the specialist?
To maintain your board certification, you have, regardless of where you are in the country, you have to maintain certification with the board of your specialty. So for me, for example, I have to maintain certification with the American Board of Surgery and the American Board of Thoracic Surgery. And most hospitals will require that their physicians maintain their certification as well. And so if their certification lapses, most hospitals will not allow that to happen.
And that would include mandatory attendance at continuing medical education conferences. There's a certain minimum number of credits that every board requires. Now, whether you could go to if you're an oncologist or pathologist, you could go to one of those conferences and miss the biomarker topic. It doesn't, it's not part of some sort of a structured checklist. Must get an update on biomarker testing. But at least when we're having conversations like this, if we weren't having conversations like this, there'd be even less chatter about it. So at least we're, again, creating a shockwave to send out information so that this knowledge will diffuse and reach everybody. Yeah, as I mentioned earlier to Chris, if there was a single lever, we'd be pulling on it. Yeah. But it's multiple levers.
Go ahead.
I think what's important is regardless of where you live or where you are, if you have lung cancer, I think it's important to, when you see a physician, and this goes across the specialties, who you're not the only lung cancer patient he's seeing that month. You want to see somebody who sees a lot, is frequently seeing patients with lung cancer and managing patients with lung cancer and helping to treat and cure patients with lung cancer.
Absolutely, and on the go-to helpline, if you call the helpline, they will help you find a center to go to for a second opinion, which often we highly recommend if you've been seen in a community setting to go to a center that has lung cancer specialists for a second opinion to discuss your care.
And the easy way to remember that is like if you think of orthopedic surgery. So I'm a mountain biker, I injured my shoulder, I needed surgery. I didn't go to the guy who does hips on Mondays, knees on Tuesdays, shoulders on Wednesdays. I went to a guy who does thousands and thousands of shoulders. That's all he does. And that was, I was back up on the bike in a few more months.
And that's a totally acceptable question for a patient to ask their physician. It is completely acceptable to ask your physician, how many lung cancer operations do you do in a month? There's nothing wrong with asking that question.
I mean, the other point I would add is you may not have access to that person wherever you live. I mean, if you live in a major city, you have that. You may be living 200 miles from a major city, and Georgia is a rural state. We have a lot of patients who don't have the ability to come to a major center. And for those patients, what we would say is it's good to have a local physician who can actually provide your care and perhaps seek a tertiary center for a second opinion at major critical decision points during your cancer journey. You've traveled through lung cancer for almost 8 years now, and I'm sure that along the way there have to be some important decisions made. And at those points, having the experts weigh in could be another way to have the best of both worlds, where you don't have to go all the way. You can still stay in your local communities and have your local hospitals care for you, but have the advantage of an expert providing some overarching guidance on your care.
Yeah, I've just seen a lot of hospitals around our area that don't have the benefit of the Go-To Foundation or any foundations that will make them aware that they kind of need to seek out a specialist. They don't know, they just hear cancer, and that's all they hear. So they just go, and then nobody's really held accountable for anything.
I think we're all working to fix that.
It's like learning a new language. I had no idea. I'm sorry. I had no idea when they said you have lung cancer.
They can't hear you on the live stream without the mic.
Sorry. Like I was saying, it's like learning a new language. You're going. It's almost like flying to a new country. You have no idea, you don't know how to navigate, and you go see an oncologist and you're expecting that they are going to tell you what's best for you. I didn't know about biomarker testing until I joined a Facebook group. That's how I found out about it. And Patty actually sent me to you, and you weren't available, so I see Dr. Coco. But but I didn't know.
You're in good hands with
He's okay too.
But I was seeing an oncologist in Gainesville who she graduated from the Mayo Clinic. I did my homework on her. She was great. She's still wonderful, but I never learned about it until Facebook. Facebook is where I learned about it. And it's honestly like learning a new language, and you don't know what questions you don't know.
So Facebook saved your life?
Yes, I did. So I joined, and that's where I met Patty, and Patty's like, you have to do this now. And by that point, I was already stage 4, because at the beginning, I was stage 3. And I had chemotherapy, I had radiation, and the chemotherapy just didn't work. So it's just, I don't know the answer, but it's like, something should be, you have stage 4 lung cancer, here's a pamphlet, these are the questions you need to have. You know, I don't know, I don't have the answer, but that's my experience.
Sounds like a
agree.
policy
And I think
issue.
Yeah, and I think a lot of us in this room care about this, and as a community, we are all going to work to fight it.
And if you don't care, he's going to come after you.
But I want to switch.
I have another question.
Okay.
I'm
Okay,
sorry.
go ahead.
So my question is related to in biomarker. You mentioned there are multiple tests. Well, I've heard of many cases. I had the same experience where a tissue biopsy was inconclusive. Perhaps there's not enough tissue. Perhaps there was plenty of tissue, but it didn't replicate the exact cancer tumors. Where does biomarker fit into that equation when the results come back inconclusive, or they come back, we assume, conclusive of no mutation? And the question is twofold. For diagnosis, and then where does it fit in terms of the same result for progression? Do you all see any progress being made that liquid biopsy is being used as a tool?
Yes, the answer is yes. Charlie, you want to
There's
take?
progress. I think there are definitely limitations to liquid biopsy, and with Jennifer, I had a conversation about this earlier. I really struggle with that term because it's not really a biopsy, but that's okay. I'll get off that soapbox. It has some pretty significant limitations. And so a negative result is not necessarily all that helpful if you don't see a T790M, a resistance mutation or something like that in a liquid biopsy. When it's positive, it's helpful. And so I think we have to our colleagues have to help us make a judgment call of when do we need new tissue versus being able to do maybe a blood test, a liquid biopsy. Because honestly, thankfully, DNA lasts really well in our preserved tissue and pathology. I don't know how many of you have ever seen that whole process, but when a surgery is done and they send a surgical specimen to us in pathology, we'll take that tissue, we'll grossly examine it, and we'll take portions of it and put it in paraffin blocks. We infiltrate it with paraffin wax. The reason I bring this up is the DNA is incredibly stable in that. I've actually gotten DNA, good DNA that I could sequence out of blocks that are 40 years old. And honestly, the quality of the DNA is just as good 40 years later as it was from a newly acquired specimen. Now, is that relevant? If you have progressive disease and I have the original diagnostic material, maybe not, because I don't know what might have changed in the interval between the original surgery and now. But sometimes we can't get new tissue. And that's when other methodologies like liquid biopsy or transbronchial needle aspiration, where you have assistance of our radiology colleagues and they'll go in and take a needle and aspirate cells, pull cells out, and then we'll make a cell block out of that and analyze that. But there are lots of limitations to all of the tests, and one of the ones we run into is the quality of the DNA.
There are plenty of reasons that the DNA quality may not be good. Some tumors tend to outgrow their blood supply and have a lot of dead tissue. And when the tissue dies, it puts a lot of enzymes out that actually start degrading the DNA. So the quality of the DNA can sometimes be an issue. There's nothing really we can do about that other than try to see if there are other parts of the tissue that are more viable. Sometimes the tumor cells are infiltrating between normal cells, and it's mostly normal. Those make me very nervous because when I get a negative result in that, I may be just testing normal tissue. I may not actually be looking at the tumor. That's why I think, you know, having the pathology group looking at it, trying to help in an interdisciplinary way have that discussion of how confident are we that the result we got is representative of the tumor. And we do that through all sorts of mechanisms. Certainly there's a lot of direct conversation back into with medical oncology, but we also have things like molecular tumor board. And I think that's really, it's relatively new in the world of medicine, but it's something that I think has made great strides in helping us keep that direct communication of how confident are we in the results, what information is now known about a specific gene or a specific biomarker, and how do we work together to make sure that that gets to the patient in the treatment fashion.
Yeah.
No, go ahead.
I was going to say, it's important to understand that any test in medicine has its limitations. And, you know, whether it's a percutaneous biopsy, a transbronchial biopsy, or a liquid biopsy, there's always going to be what we refer to as false negative tests. And, you know, so to check, to do a biopsy, and the biopsy, you know, you're not sure that the biopsy actually has a sample of the tumor, to run biomarkers on that sample is of questionable significance because you may not have a representative sample of the tumor. And so, you know, sometimes it's necessary to do multiple biopsies. You know, we all hate sending patients for multiple biopsies because it's uncomfortable, it hurts, you don't want to have to do it. It's not fun for the patient. But you know, sometimes it does take multiple biopsies. And you know, I've had situations where I've had to do a surgical biopsy purely to get enough tissue for our medical oncology colleagues to be able to do my biomarker testing. When they did a percutaneous biopsy, there wasn't enough tissue. There weren't enough cancer cells there to run the biomarker testing, so we had to do a surgical sample for, you know, someone that was not resectable. And you know, you don't want to do surgery on somebody who's not resectable, but if there's a possibility that we can do some biomarker testing and change their course of treatment, then that may be worth it. And it's you know, in situations like that, it's helpful to have a multidisciplinary team of physicians kind of working together and looking at the cancer cases, what we refer to as our tumor board, that has oncologists, surgeons, radiation oncologists, pathologists reviewing cases.
Yeah, so I'm going to stop you and just go back a second. You used a lot of very big words there for some of the patients who might not know. And actually, Bill and I were very much on the same page, because what I was going to say prior to your question was that one of the issues with testing is also lack of tissue. You hear that a lot. We didn't test because we didn't have enough tissue. So what are the ways that we can get biopsy tissue? You mentioned a few different ones, but can everybody explain that to the audience, the different options?
I could take a crack at that. I mean, I'm often the patient advocate, so I don't do the biopsies.
Okay.
But I have to explain it to them. So sometimes they just put a little lidocaine on your skin and they push a little needle in and they get it out. Well, it's usually a longer needle, more than just a little. But we usually try to have the patient not see how long the needle is. Then they may need to give you some sedation and take you into pulmonology suites and put a long camera, flexible camera, down into your airways to get that tissue. And so you're groggy, you're going to need a driver to take you home because you got sedation.
And that's a bronchoscopy.
That's
right?
bronchoscopy, yep. And you can get lymph nodes, you can get lung tissue, all sorts of goodies down in there. And then sometimes that's not enough, and if it's a life and death type of situation, because you might get the wrong drug, we might need to give you general anesthesia. So you're coming in for a pre-op at the crack of dawn, you're going to the operating room, you're going to wake up with a bandage on you, and you actually had surgery. And I think a lot of patients probably might be scared of that. And I think that, you know, a lot of oncologists might not want to push their patients to get a surgical biopsy. But now, I mean, in the last 5 years, it's a critical decision, and I think it's important to let patients know that, you know, this is something that we need. It's going to really affect what we're going to do, and we're not going to go backwards in time and do it the old way and just hope that you don't have a mutation or what have you. So there's minimally invasive all the way to, you know, possibly needing a surgical biopsy. And the good news is today, the surgical biopsies can be done with camera. So you might wake up with what, 3 bandages?
Sometimes less.
3 or 2. Sometimes some places do it with 1 bandage. Unbelievable.
Can we go back to the issue of not enough tissue for a second and talk about the liquid biopsy just one more time, if we could just go back to it. So my question is, I hear you about the negative, right? But what about false positives? Does anyone know the percentage, the current percentage of false positives with liquid biopsy?
That's really hard to establish. So the short answer is we don't have accurate numbers, although there are analytical and statistical methods we can get at sort of what we believe it is below some certain percentage. But really the accuracy of that is, it's a statistical thing. So it's really hard to know. There's so many factors that play into whether a liquid biopsy is going to be positive, even in a case where we know the tumor carries a specific change, biomarker, for instance. And so with that in mind, you know, you have to, we spend a lot of time thinking about, you know, is this a tumor that the cells are growing very rapidly? The more rapidly the tumor grows, the more DNA it's going to shed out into the circulation. So there, in fact, that's why recurrence actually is a really great time to contemplate something like liquid biopsy, because you know there's active growth of the tumor and those cells are turning over and then they shed DNA. A stable tumor, we don't know as much about how quickly they shed DNA. And it is truly the needle in the haystack, because what we're trying to do is pick out that DNA or that biomarker from the tumor in a background of normal. And it can be a real challenge. There's a lot of progress being made, and while the guidelines don't make any specific recommendations, in fact don't recommend things like circulating tumor cell analysis, this is coming as well. There some fantastic work going on right now at places like Georgia Tech, where they're using physicochemical means of isolating out of the blood individual live tumor cells. And our technologies in the clinical laboratory have gotten good enough now that while there are not really many clinical labs able to do it yet, we can take 2 or 3 cells and sequence that DNA if they're live cells with good quality DNA. So the field is going to change really quickly some more, but there are just a lot of factors with the liquid biopsy that yield potentially more false negatives than false positives, but we really can't say what the false positive rate is.
So from a medical oncology point of view, when are you ordering liquid biopsies? When do you feel it's appropriate?
I would say it's increasing the situations where we use. So for routine clinical care, when a patient is diagnosed with stage 4 lung cancer, we do the tissue-based testing. Sometimes if there's not sufficient tissue, I would go get a blood test and then schedule the next biopsy, because blood test tends to come back in 7 or 8 days. And I would cancel the biopsy if I have the information from the blood. So we're beginning to use it a little more, even with tissue-based testing at the front end. Definitely during the course of treatment, we're using it for assessment of resistance mechanisms. What is the future hold for liquid biopsies? I think there are some promising avenues. One, of course, is using liquid to know, even after you started therapy, how likely you're going to be a long-term beneficiary versus a short-term beneficiary. We have some data that if you have somebody on an EGFR inhibitor, within 3 to 6 weeks, you can look at their blood and be able to say who is going to be in the better performing group versus in the less well-performing group. what is that information going to tell us? Well, maybe we can do something even as early as 6 weeks. These are all responding patients, but if I know that the profile is not satisfactory, I might become a little more aggressive at that point rather than waiting until the recurrence happens or progression happens. Another point is to see if we can predict after surgery who's going to recur and who's not going to recur. Can liquid biopsies help us there? How about screening, early detection for lung cancer? When you have a CT scan, you find a nodule. Instead of doing a biopsy, can we use liquid biopsy technologies? These are further down the road, but that's the promise of the liquid biopsy technique.
We've got 3 questions. Okay, this was for Dr. Hill. He earlier said something about private mutation. Is that the same thing as a deviation, or is it something completely different?
So a private mutation is one that's unique to a given patient. It's one that we haven't seen in lung cancer before. And you'd like to think that doesn't happen that often, but it seems like every week that I'm reviewing sequencing data, I have at least 2 or 3 patients that we have sequencing data on that none, I can sit there on Google and all of the clinical databases all day and not find that mutation. And so that's what I mean by private. It's one that we certainly, it's a variant of uncertain significance, of VUS. We don't know what it means. We can establish that it's real because of some of the metrics we use in the sequencing. But in terms of what the clinical significance of it is and what it means for that given patient, then we have to dive into other systems to try to guess, because at that point it is a bit of a guess in a given mutation that's not been seen before.
Are you using data? Are you keeping data?
Absolutely we are. It's one of the big things that I think cancer centers have become very conscious about, is archiving our patient data, particularly the sequencing data, in a way that we can do research on, that we can do retrospective analysis on, because if we don't have access to that and a new drug comes out and it's targeted, this definitely came up with things like the NTRK inhibitors. If we didn't have stored data on that, then we got to start over and test people again and go back and retest. If we already have that data, then it's just a matter of remining it, right? Because that, since it wasn't targeted, probably didn't change in the interim. But data management, just to give you an idea, I'm sure all of you have various computers and phones and so on with lots of memory in it. The main computer that we use in my laboratory to do sequencing on has 29 terabytes of hard disk storage, and it's more than half full. It has 128 gigabytes of RAM. It has 72 processors in it. It's more powerful than the old style mainframe computers that we used to use. And that's still not enough computing power. I'm having to update my computers on a relatively frequent basis. There are a lot of privacy issues with doing the things we really want to do. We'd love to store a lot of that data on the cloud. Having said that, cancer centers across the country are doing a much better job of data sharing, because even a cancer center the size of Winship, we're going to have patients that are incredibly rare and may have a mutation that we haven't seen before. That doesn't mean that the Fred Hutchinson Cancer Center in Seattle didn't have a similar patient. And so there are now a lot of initiatives amongst the cancer centers to share data, be identified, so that we deal with some of the privacy issues. But that way we can start to deal with uncommon things, because those are the biggest challenge.
These databases are also important for common things. For instance, 6-7 months ago or a few months ago, when we started enrolling patients to the KRAS G12C trial, we just went back and worked with Charlie and said, hey, who are all the patients we've tested in the past year and a half who had G12C? So we got a printout from him about X number of patients. So we said, okay, let's go through each one of these patients and see what part of their journey they're in and who among these might be interested in participating in the clinical trial. So within a week, we were able to identify a few patients, and we reached out to them and say, hey, we have this promising option. Some of them were at the right point for them to enter the trial. Some of them, it would be an option a little down the road. So knowing these mutations, the results, having the data sharing and data analysis ability is very helpful, even to go back and find information that can help certain patients.
So let me get this straight. So we're going from, should a patient have to ask for biomarker testing, to here the university calls you and says, hey, we have a new trial for you? That's a complete 180. That's amazing. So hopefully someday that's what oncology would be then. Everyone gets tested, and when a trial opens, you can print out a list and chase people down and leave no person behind.
And I'll add, we're trying to do that from the patient perspective. We have a lung cancer registry, which if you're watching on the live stream, probably the information has gone across the bottom, but it's www.lungcancerregistry.org, and we encourage everyone to join it. We've taken it from where it used to say, are you EGFR positive, or do you have an ALK fusion, do you have this, to now for KRAS, it doesn't just say, do you have a KRAS mutation, it says, do you have G12C, do you have G12D? And patients are starting, we had a lot of people in the room tonight say they were EGFR exon 19. We're really encouraging some of this information to be shared with the patients so that they can identify things, but they can also use tools like we have, because we also reach out and say, hey, there's a new clinical trial for you if you have this specific marker. So I do think it's a community effort on all parts, but some of the sharing the biomarker testing results with the patients and making them aware, to Terry's point earlier, is really important as well.
Going back to pre-screening. Going back to the pre-screening,
may need a quick battery change.
Like him.
It's on. There's one here.
Hello? Going back to the pre-screening, is there a role with any of this family history? My dad died at the VA in Asheville of stage 4 lung cancer, and his mother, I found out later, I didn't know her, she had stage 4 lung cancer, and she passed away from it. But they were all in their 60s and 70s, and I was 45. So I don't know if there's a role either in the biomarker or even at the pre-screening, if there's, I don't know, I don't even know what I don't know, but is there a role anywhere in this with family history at all?
So most of the mutations that we talk about in the realm of targeted therapies for lung cancer, they are not inherited from parent to the next generation. They are mutations that develop during the course of one's own lifetime. That having said, one exception I would throw is T790M sometimes can run in the germline material, so it can be inherited. It's very rare, but we have seen patients. I have a family of patients. I took care of the brother, and now I'm taking care of the sister as well. And they both have T790 in their germline. So that's one mutation I know that can increase one's risk of lung cancer. We are still trying to understand if somebody has T790 and if they have an 18-year-old at home, what do they do differently for that 18-year-old? So we don't know that information yet. It's not like the BRCA test for breast cancer where you can predict there's an X% lifetime likelihood of somebody developing. So if you're past your reproductive age, this is what you can do and reduce your risk of developing lung cancer. Most of the mutations that we talk about are all things that happen during one's own lifetime. And that's a common question patients ask. What does this mean for my brother, for my kid, for my parents?
Well, yeah, it was my direct dad. That was my dad.
Right.
And his mom. So I just didn't know if there was any.
Right. A lot of times it's common risk factors in the household. For example, we still unfortunately see 80 to 85% of the lung cancer patients get it from smoking cigarettes. And sometimes the exposure to tobacco smoke is shared between family members, or that's a habit that's been seen in generations of a particular family. So there are some common risk factors that could contribute to it. we don't have a lot of genetic syndromes that link with lung cancer that we're aware of.
But with that said, there's a lot of research being done to find better screening tools, so that someday you can get a blood test once a year and screen for lung cancer. But right now, screening for lung cancer, the only proven method is using a low-dose CAT scan, and that you have to screen a ton of non-smokers to find any at all. So that's why it's really only being done in smoking, people with extensive smoking history.
Although to that point, there's a very specific criteria for who is eligible and covered under insurance for low-dose CT for screening, but NCCN recommends, they often call it the NCCN 2 group, it's lower risk than the main covered group, that if you have additional risk factors but a lower smoking history, that you could be covered. And one of the additional risk factors that's listed is family history of lung cancer. So it's a group that people are very interested in, and how this family history plays into the potential risk that would then make you eligible for screening.
I have a question. Out of the biomarkers that have been identified, how many have an FDA-approved targeted therapy?
For lung cancer today, 5 genomic markers have FDA-approved targeted therapy, and PD-L1 is the 6th marker for which there is immunotherapy. But having said that, I don't want you to get that number 5 too entrenched in your mind, because that's what we want to improve upon, and that's coming rapidly. So I would say there are at least half a dozen other targets for which there are treatment options. Like I mentioned, RET is one, MET is one, and we hope that KRAS G12C will join that list very soon as other markers with proven targeted therapies.
Lisa's got me curious. How many mutations are there that there are clinical trials for?
There are, there are, as Charlie said, you start getting into this lesser and less common mutations, and now when you have a promising drug, we really have to depend on the entire community to identify patients that would be appropriate for these sort of trials.
So there might be half a dozen FDA-approved drugs, but there's probably
there are
dozens and dozens of
there are at least a dozen other targets with clinical trials that are ongoing.
And that you'll never know about if you don't get biomarker testing.
And broad panel biomarker testing that covers those particular trials.
Back to the, she was asking about the history of family history. The TP53, does that have something to do with it when it comes to your history? Because I know that, like on my side, it's been on our side of the family, on the maternal side, we've had tumors that have, it's a tumor suppressor gene, of course,
Right.
So, but they grow out of control, and we keep having them grow out of control, and then we end up getting lung cancer and things like that. Would that allow someone to test early for lung cancer? Say if they've had it in their history before?
Right. So the P53 mutations can occur in 2 contexts. One is something that develops during the course of one's life, and something that's passed on from your parent. The genetically acquired P53 is a very rare genetic syndrome, and those patients are prone to many cancers beyond lung cancer.
Yeah, we've had 6 or 7 in our family.
Yeah. Meaning, when you look at the population at large, the percentage of families that have these P53 mutations inherited from one generation to the other is relatively small. But when it happens, obviously, that's an unfortunate situation where that puts the individuals at risk for a number of cancers.
But once you know that, then you really should, and this is where having that conversation and involvement, once we can establish that that's a germline or inherited P53 and that there is increased risk of cancer, everybody in the family then should be surveilled more frequently.
Thank you.
Right, for cancer, because they're at risk. There's an argument, although I'm not sure insurance would pay for it at this point, for once you know the specific P53 mutation, to then consent everybody in the family and test them, because if you don't carry it and you don't, you got 2 copies of the gene, and so you might not have inherited the bad copy if you're a child of a parent with it. So in those particular cases, that patient would be surveilled just like anybody else in the general population if they know they don't have it. But if they know they inherited it, then that person really, it would be very valuable to follow much more closely.
So I'm going to go back to the other question in terms of, with KRAS, you guys were able to pull out those individuals and reach out to them about a clinical trial, right? Now, when you did that, was that only with people from Emory, or at the same time, did you send something out to the other hospitals and say, hey, we have this trial open? And then the other part of the question is, if that trial wasn't at Emory, and it seemed like it was a possible opportunity, would you go back and look and see who could benefit from it if it's not in a trial at Emory, and send something out to them?
So this one was database at Emory. Whatever we had done the testing for, whichever patient, we had access. And in fact, there's one patient who's on our AMG 510 trial who had come to us once before and is being treated at the community by one of my colleagues, so was being treated. So when that patient's name came up, I knew who was treating that patient, so I gave that individual a call and said, hey, how is this patient doing? We have a potential clinical trial. And a couple of months later, he called me back and he said, listen, I want to send this patient to you because I think it's the appropriate time. And she's on the trial now. So anyone who's in our database. Now, there are some national databases. We're part of this group called Orion, which is a research information exchange network, as they call it. So information is shared across academic medical centers that are part of this group. And the whole idea is to look into those rarer mutations where N of 1 at a given institution may not help you learn much about that patient's course. But when you pull the data and you find out 10 of these situations, then maybe there is some strength in numbers. You can start looking for patterns there. Now, are there patients where we have found rare mutations, we did not have a clinical trial? The nice thing about the lung cancer community, it's a very close-knit community. I just text half of my friends across the country and say, who has a trial for this? And within 15 minutes, they text me back. And by show of hands, I know which is the nearest place where I can get the patient to, and we get them to. So that's the power of technology as well. And having these sort of close-knit communities where you can use the advantage of everybody's expertise to help to manage the patient in front of you.
And we do that. If a patient comes up at Grady and they are a potential candidate for a clinical trial that we don't have it open there, but we do have it open at Emory, then absolutely we will reach out to our colleagues at another institution and say, hey, would you consider this patient? And I think that's just part of being a part of the lung cancer community in the city of Atlanta.
And from the community medical oncologist perspective, it is wonderful when we have clinical trials and they're available and open and we have slots. However, I think the most important part will be to bring those clinical trials closer to the patient's home in the community. I don't know if many people can drop everything they're doing, their life, and then move 200 miles or 2,000 miles away and participate into a clinical trial there. So that's why we're really trying in the community to open those trials and work with university settings, with other bigger centers to bring those trials closer to home.
Well, that's a great point. I think we need to have trials available. Trials should also be more closer to real life rather than have pristine criteria that most patients would not qualify for. In Georgia, we're lucky Angie Patterson is here. The Georgia Corps has made it its mission to have trials available at various sites deep into the state so patients have access to participate. Centers like Winship have community partnerships where we're trying to have other sites have trials available. I think what we can all say with confidence is that research has really helped us move the outcomes for patients forward than we could have ever imagined a few years ago. Considering how far left we have to go, we just need to make it even more onerous upon us to have an extensive network of trials available for our patients and make it easy for them to participate in these trials.
So let's go to a challenging point. We've made a lot of progress, particularly in non-small cell. We said we'd come back later. Where do you see biomarker testing going for small cell and some of the other areas that have not so far had as much progress with biomarker testing and targeted therapy?
Sure. So in small cell lung cancer, it's been sequenced. There are many papers published. We know what is the mutational landscape. The problem there is it's not one mutation that's driving the cancers. Small cell lung cancer in 99% of the patients is related to smoking cigarettes. And because smoking can cause multiple mutations at the same time, tobacco carcinogens, these tumors are not driven by one pathway. So just blocking the EGFR is not going to give you any favorable outcome because the tumor is dependent on 100 other pathways. So that's why we're finding it challenging to develop targeted therapies. This also holds good for squamous cell cancer to some extent. Thankfully, we have a step forward in small cell lung cancer with immunotherapy, and now there's a lot of studies ongoing building on the success with immunotherapy in small cell lung cancer, identifying patients who might benefit from immunotherapy, developing combination approaches. I think that's an area where we're likely to see more successes in small cell lung cancer, at least in the foreseeable future. Whether there are certain targets that can be targeted, that's still being studied. There are a few vulnerabilities in small cell lung cancer that can be studied, and we are doing clinical trials for those patients. That's a subset of all small cell lung cancers.
Okay, great. Well, we are almost out of time. I'm going to give all our panelists one opportunity to mention something they haven't talked about yet. If you have anything you want to bring up that you think our audience should know about that you haven't gotten a chance to. Anyone?
I would just say that you are making a difference for us. We learned from you the energy, the inspiration you bring to advocating for lung cancer, advocating for molecular testing is critical. One piece of information that we should all take home is that if we can diagnose more lung cancers early, we can cure more patients. Unfortunately, if you look at all the subjects in the country eligible for screening for lung cancer, less than 5% are getting screened. We all need to work together to make sure that every subject who's eligible to be screened for lung cancer is screened. So 80% of lung cancers are diagnosed in stage 1 or 2, and where we have better ability to cure patients than patients being diagnosed at stage 4. So that would be my parting message.
Great message.
I love that message. I mean, you catch these cancers early, you know, it's a completely different journey. So yeah, I endorse that. I would echo Dr. Ramalingam's first comment, which was, you guys really have incredible power to make a difference. Chris Draft has helped a lot of us realize that physicians have been largely operating in kind of echo chambers. We only see you in a chair or on a clinic bed or in the hospital in a gown. We don't see you outside of that. I recently surveyed a bunch of my colleagues. Have you ever talked to someone with stage 4 lung cancer outside of a hospital? 0 for 8. They had never talked to a person with lung cancer. They'd only talked to patients with lung cancer. And if you guys can get in our face more and let us know that you're people, share your stories, it will change us, especially those of us who are academically oriented. We'll work even later hours, more nights and weekends. But more importantly, I think that it sets off a chain reaction where we take the time to connect with industry partners, to connect with academic partners in other institutions, to connect with people in the community, and together we grow a much larger network to make a difference because, I mean, we just cannot forget that lung cancer kills more people than the next several cancers combined, and it really needs to be a priority, and to be a priority amidst all the noise in the media, we have to create massive shock waves that can make a difference. And early detection through lung screening is one of those shock waves. Increasing treatment options through targeted therapy is another. And biomarker testing is another. And we just have to keep pounding and pounding so that we can meet Chris Draft's dream of making sure that there's 100% diffusion of knowledge so that we can really move the needle and let people get to a day where no one dies of lung cancer.
Yeah, I guess my parting words, I just saw, I just looked at the most recent cancer statistics that were published for 2000. They're a little bit of lag there. They were published for 2017, and the year from 2016 to 2017 saw the single biggest one-year improvement in lung cancer survival in the United States. And I think, there's a lot of things that go into that. Biomarkers is one of them. Immunotherapy is another. Screening is an important part of that. Improvements in radiation and surgery, and then I say this last because in my mind it's the least important, but like decreasing, tobacco cessation and decreasing use of cigarette, decreasing rates of cigarette smoking, and it's making a difference. But that 1 year improvement that has been the biggest 1 year improvement was a 4% improvement in survival, right? So I see that there's still a lot of room for us to continue to improve, and I think that advocacy groups, patients, we all kind of partner together in improving lung cancer survival. Can make
Stay engaged and get more people to engage, please. It makes a difference.
The only thing I would add to that is, and this is specific to my specialty, thank you for having the opportunity to be here. Pathologists don't often get to connect real patients with the specimens, the blood tubes, the samples that we get. And I think it's incredibly important. One other hat that I wear at work is I'm the residency director for our pathology residents, and it's incredibly important to me that they understand when they get a blood tube, that's not just a blood tube, that's a patient, and that's a real person with a real family. And I just am really happy to be here and have the opportunity to meet all of you.
Thanks. I think that's great. So we have a couple thank yous and some housekeeping items. We want to thank all our supporters of the Lung Cancer Living Room: AbbVie, Amgen, AstraZeneca, Bayer, Boehringer Ingelheim, Bristol Myers Squibb, Celgene, Dignity Health, Foundation Medicine, Genentech, Lilly, Medtronic, Merck, Novartis, Takeda, and Tesaro. We really appreciate all of your support and being able to be here in Atlanta tonight and bring this live across the world, but particularly to the people in the audience. Events coming up for GoTo Foundation, we have 2 5Ks, one in Southern California, February 9th, and one in Phoenix, Arizona on February 15th, with many more coming in the coming year. Our next living room will be in California out of the San Carlos headquarters on February 18th, and it will feature Dr. Jonathan Reese of UC Davis Comprehensive Cancer Center. And as I mentioned before, if you've not done so already, please consider joining the Lung Cancer Registry at lungcancerregistry.org. And our biggest thank you of all to our panel for joining us tonight, and to all of the patients and caregivers who are in the audience who were able to make it.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be
Everyone, that was great.
Thanks for coming to Atlanta.
Just you and me.
I got to come because it's closer to our office.
We'll be family.
This is the first one of these I've done, so it's a fun change.
Wow, you're like
just wait and see.
Moderated other panels, but I've never done the living room, so Danielle Hicks.
So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this.
Mine's all like strapped on.
Like sailors in a tempest. Like sailors in a tempest. Together. And it could be just you and me. We'll be